A great honor to welcome you to ASLD joint meeting, Asian and American Perspective on the Management of Viral Hepatitis C. My name is Dr. Panida Tautaisi, and this is Professor Rino Awanikani from Indonesia. We are the moderators for this session. As we know that hepatitis C is a major cause of chronic disease worldwide, the development and introduction of DDA have changed the HIV treatment landscape due to high efficacy, low side effect, and short duration of the treatment. This symposium number 2, hepatitis C, we will cover who to treat and with what. We will cover the 3 topics. First is ASLD, IDSA guidelines, and how different between guideline and real-life practice. And the last topic this cover is what's about the Asian perspective. We have the 3 honorable speakers to talk on this session. So let's start with the first topic. What is LD IDSA guidelines say? This will be talked by Professor Bill Ray Kim. So ladies and gentlemen, please join me to invite Professor Kim, please.
Thank you. Thank you. As I remarked earlier, this is really a pleasure for ASLD to be performing this joint session. I thank everyone for being here. So my job is to talk about ASLD IDSA guideline with regard to who to treat and with what agent. So let's start with the basics. The goal of HCV therapy, according to the guidance, is that it is to reduce all-cause mortality and liver-related health adverse consequences, such as end-stage liver disease and hepatocellular carcinoma. This is by achieving virologic cure, as evidenced by sustained virological response. So you achieve SVR first, and then you want to achieve long-term outcome. At the beginning of the guidance, going back to July 2014, this is what the guidance document said, when and in whom to initiate treatment. And it said treatment is recommended for patients with chronic hepatitis C infection. However, there are some criteria with regard to who need to be treated first. The highest priority was patients with advanced fibrosis with compensated cirrhosis, as indicated by METAVIR F3 or F4, or liver transplant recipients. The second tier, or high priority, as necessary based on available resources. If you can get to these patients, go ahead and treat those patients. And that is patients at high risk for liver-related complications and patients with severe extrahepatic hepatitis C complications. So who are they? So this is a table that goes into the details a little bit more. The highest priority were patients with METAVIR F3 or F4, liver transplant recipients, then kidney disease, type 2 or 3 essential mixed cryoglobulinemia with end organ manifestations such as vasculitis, and then proteinuria, nephrotic syndrome, or MPGN, etc. So these are patients that need to be treated as soon as possible. And the next level is lower fibrosis stage at F2, or HIV or hepatitis B co-infection, other coexistent liver disease such as NASH that may synergistically accelerate progression of liver disease. Debilitating fatigue in some of the patients were considered to be an indication, type 2 diabetes and porphyria cutánea tarda. So that was what was proposed in 2014. And for those of you who were at ASLD last year, there was some demonstration that was protesting why ASLD discriminates patients based on fibrosis stage. Don't patients with all hepatitis C need to be treated, was their argument. In part, as a response to that, the newest guidance document at hcvguidelines.org As of October 2015, the tier system is de-emphasized or eliminated. So the current version says treatment is recommended for all patients with chronic hepatitis C infection, except those with short life expectancies that cannot be remediated by treating hepatitis C, by transplantation, or by other directed treatment. Patients with short life expectancies as a result of liver disease should be managed in consultation with an expert suggesting this is a liver transplant situation or management of chronic liver disease. So this is an evidence that there is a tension between a group of people who want to see universal treatment. If you have hepatitis C, you need to be treated, versus we can't treat everyone possibly, therefore we may need to prioritize hepatitis C treatment. The American attitude has shifted towards a universal treatment, but as you go into communities that have more restricted resource available for hepatitis C treatment, then priority-based treatment guideline may make more sense. So what are the pros and cons of these approaches? So if you look at the universal treatment, the big downside is cost. As everyone in this room knows, hepatitis C treatment is expensive. If you're going to treat millions of those patients, then you're going to take billions of dollars to spend. Then you have a patient and public anxiety that if you are not selected for treatment, then you feel that you're left out and you are worried that your liver disease will progress before the system provides you with treatment. That will be an advantage for universal treatment. And then there's always criticism that the medical community may be advocating universal treatment because it generates a lot of income for the pharmaceutical companies, whether that is fair characterization or not, but there is concern. On the other hand, one can make a legitimate medical justification that not all hepatitis C patients need to be treated or not treated right away anyway. So you can make a good argument that patients who've had hepatitis C for decades, they can wait a year or two or three when the resources are available for them to be treated. Whereas there may be some ethical justification as well. So on the one hand, people criticize there is no ethical justification discriminating one group of patients versus the other, but there are other situations where healthcare resources are prioritized and there is no ethical problem. And then as you prioritize things, what we've seen in the US is that the treatment criteria become very complicated and it takes multiple number of people to navigate through the system so that one can properly prioritize patients according to the scheme. So these are some of the considerations. And as I think about these tension, you can make a contrast between H. pylori and hepatitis C virus infection. Both are pretty common. H. pylori probably more common than hepatitis C. It causes benign consequences such as gastritis due to an ulcer for H. pylori. Hepatitis and cirrhosis is not benign, but it's not malignant. But there are malignant consequences. They are all cancer-causing infections, gastric adenocarcinoma or multiple lymphoma for H. pylori, as you know, hepatocellular carcinoma for hepatitis C. Cancer risk may be mitigated by eradication of both infectious agents. Treatment is available to cure those patients over 90% of the time for both situations, and both treatment is safe. But then things start to break down a little bit here. H. pylori treatment costs about $1,000 in the US. It only lasts 2 weeks, whereas hep C treatment, as we talk about here, may cost up to $100,000. It takes longer period of time. And who treat those patients? Primary care docs or some GI doctors for H. pylori, GI hepatology or infectious disease for hepatitis C, limiting the manpower that is able to take care of those patients. There is a well-established test and treat guideline for H. pylori. We are arguing what may be the best option for hepatitis C. The controversy with H. pylori is mostly among the physicians. And there are physicians going back and forth which might be a better option. But somehow in hepatitis C arena, there's tension is displayed out in the public, there's a controversy between the public and the medical professional group as well. So there is some lessons to be learned by looking at H. pylori in my mind. So as we think about which strategy is wiser for public health to treat hepatitis C patients, let's think about this just a little bit here. I'm trying to draw a cartoon to demonstrate what natural history of hepatitis C looks like without treatment. So let's say this big box is a universe of hepatitis C treatment, the whole patient group in the population. Not every one of those patients will experience bad outcomes, such as cirrhosis, liver cancer, or death. So it's a relatively small circle. Then you introduce treatment. In the old days, we had interferon and ribavirin, which was not very effective. Maybe 40%, 50% in genotype 1 patients responded with SVR. So if we bring over this box and superimpose the circle and think about what patients are we helping by giving them SVR. So we feel good when a patient achieves SVR, but if you think about it, people that you benefit are people who are in the intersection between these two circles. So people who are supposed to, or is expected, or destined to have bad outcome, if they achieve SVR, the natural history in those patients is altered. But patients who are not in those circles, who are not going to have problems, if you achieve SVR, you haven't done too much for those patients. So it is relatively small proportion of patients, especially with interferon ribavirin era, that you're helping. Now we introduce DAA. But you use the same circle, you have the same strategy as before, you just improved SVR, and that's what you get. The intersection remains the same. So you are not achieving a lot more benefit from using DAA. So if you have a strategy to prioritize the patients, it will look like this. You go from the separate circles and you prioritize so that circles come together. So you focus your target your treatment to people who are going to have bad outcomes. So you cover most of the circles, and there are patients who still will not achieve SVR because our result is not 100%. Contrast that against universal treatment strategy, and in this cartoon that will look like this. And you have a big wide circle, and you treat a lot of patients, but the benefit that you gain remains the same. The circle of patients that you will have bad outcome, and also notice that just because you're treating everyone, that the section of the pie that will not benefit because they failed to achieve SVR, they are the same. So in my mind, in a situation where resources are limited, trying to prioritize and try to make the circle as small and tight as possible around people who are going to have bad outcomes, that would be the wisest way to go about to treat patients. So if you're going to prioritize who is at risk for accelerated fibrosis. And this is a case of mine, a 56-year-old mechanic person who progressed from F0 in 2005 to F4 in 5 years. He became from normal, no fibrosis to F4. And you can argue there's a biopsy variation and whatnot, but this patient has genotype 3, high BMI, which may be the factors that accelerated this progression. So there are non-modifiable host factors that will accelerate fibrosis where they are right now with fibrosis stage, inflammation grade, older age at infection, male patients, organ transplant, these are the factors. Modifiable factors such as alcoholism, NAFLD, obesity, insulin resistance can be another aspect to think about. And then there's viral factors such as genotype 3, Hep B or HIV co-infection. Those are some of the markers that you can use to prioritize patients. So in summary, as to the WHO, the US guidance says everyone, and we talked about social justice versus medical necessity. This becomes expensive. An alternative strategy may be to prioritize based on risk factors, which makes the whole thing more cost effective, and there's a better support for test and treat strategy meaning that if you have a policy that you're going to treat everyone, and then you start to go out and screen patients to look for more patients, then you're going to run out of money pretty soon to treat all those patients. However, this alternative prioritization scheme should not be too restrictive, otherwise you're going to be missing some of the patients who you need to help. Then I'm supposed to talk about what agents to use. And if you're just in the last session, there were a lot of data presented, so my job got easier a little bit to talk about different treatment strategies. This is just to remind everyone that the genotypes that we're talking about is genotype 1, predominantly B, and 3 and 6. There are some 2 in this area as well, so I'll limit my comments there. These are some of the DA regimens, depending on the country, that are available here in Asia-Pacific countries. Sofosbuvir, ribavirin, declatosphere, snuplevir, sofosbuvir, declatosphere, ledipasvir, sofosbuvir, and the 3D regimen. And there's a pending regimens as we talked about during the lunch session. And there's various doses, durations, and then genotype-specific indications. So I hope you're familiar with these agents. I just wanted to name the drug to familiarize. So this is the best I can do, try to condense the whole US guidance for genotype 1 patients into one table. So when the Merck product gets approved, I'm going to be in trouble trying to squeeze that into this table. So just to going through this, for ledipasvir and sofosbuvir, treatment-naive patients without cirrhosis, you use no ribavirin 8 to 12 weeks depending on the viral load, and you get SVR 99%. Treatment-naive cirrhotic patients and treatment-experienced non-cirrhotic patients, you don't need ribavirin, 12 weeks, excellent results, 94 to 95%. Treatment-experienced cirrhotic patients, if you don't use ribavirin, you need to go 24 weeks, expecting 97 to 100%. And more recent data says if you use this combination in treatment-experienced cirrhotic patients, you can add ribavirin and get away with 12 weeks without compromising the SVR too much. The 3D regimens, 1B, cirrhosis, no cirrhosis, you can go 12 weeks without ribavirin. 1A, no cirrhosis, 12 weeks with ribavirin. Cirrhotics, 24 weeks with ribavirin. The declatosphere sofosbuvir regimen for all treatment-experienced situation, no non-cirrhotic patients, no ribavirin for 12 weeks, high response rate. If you are cirrhotic, then whether ribavirin is needed or not, the guidance document doesn't specify, but it does recommend going on for 24 weeks in order to achieve high sustained virologic response. Symipivir, sofosbuvir, which doesn't tend to be available in Asian countries too much. Same sort of a thing as the declatosphere sofosbuvir, 12 weeks, non-cirrhotic, no ribavirin, longer duration treatment with or without ribavirin for cirrhotics. So that's genotype 1. We talked about this data that in patients with advanced liver disease, I don't want to go into the specifics, but just remind that this is still a suboptimal response if you let the patient progress to decompensated cirrhosis. Treatment for genotype 2, treatment-naive patients, sofosbuvir ribavirin for 12 weeks in non-cirrhotics, 16 weeks for cirrhotics. Declatosphere sofosbuvir for 12 weeks if intolerant to ribavirin. Treatment experienced, prior PEG-riba failure, soft riba for 16-24 weeks, and then triple sofosbuvir, PEG, and ribavirin for 12 weeks. Prior sofosbuvir ribavirin regimen failure, those patients treated with the declatosphere and sofosbuvir for 24 weeks with or without ribavirin, or the triple combination, the boson combination, sofosbuvir, PEG, and ribavirin for 12 weeks. I'm going a little bit fast because this is all on the guidance document. We talk a lot about genotype 3 patients. This is what the US guidance document says. Sofosbuvir, ribavirin combination, the first row, regardless of the cirrhosis status, treatment-naive patients, we treat for 24 weeks. Declatosphere sofosbuvir for patients who are naive or PEG ribavirin failure. In non-cirrhotic patients, go 12 weeks. In cirrhotic patients, naive, you use ribavirin or not ribavirin for 24 weeks. For prior PEG and ribavirin failure, you use ribavirin for 24 weeks. For patients who are prior sofosbuvir and ribavirin, regardless of their cirrhosis status, you go to 24 weeks with ribavirin. Sofosbuvir and pegylated interferon with ribavirin can be sort of a backup option without regard to cirrhosis or without regard to prior treatment response. This goes on for 12 weeks. This was shown just about half an hour ago, emphasizing that the genotype 3 patients are pretty well served if they are treatment naive and non-cirrhotic based on what's available currently. However, when you go to treatment experienced cirrhotic patients, genotype 3 remains a challenge, and you saw some further data about genotype 3 patients, so I won't go into that in further detail. There were a lot of discussion about genotype 6 patients in the last hour. The guidance document says levetiracetam sofosbuvir for 12 weeks, or you can use the triple sofosbuvir pegylated interferon ribavirin for 12 weeks. You also saw this data, the Electron 2 study, 24 out of 25 patients with Harvoni for 12 weeks resulted in SVR. So, US guidance with what? In my mind, there are a few things that you need to think about before deciding what to use. On the one hand, you have genotype, 1A versus 1B, 2 to 6. On the other hand, you have presence of cirrhosis, non-cirrhosis, or if there is a hepatic decompensation. These patients tend to have low SVR, longer duration. We tend to use ribavirin more often, and then more importantly, these patients need additional hepatology care with regard to evaluation of portal hypertension and surveillance of HCC. And then the third factor is prior treatment experience. As DAA regimens become more common, this becomes a little bit more problem because we used to just deal with pegylated interferon ribavirin failures, but now we have DAA failures with NS5A resistant variants that makes the consideration a bit more complicated. I think the principle is trying to cure patients in the first attempt so that we don't need to deal with treatment failure issues. So that's a whirlwind tour of HCV guidance document for the US, and I thank you for your attention.
Thank you, Professor Kim, for a very informative speak. And our second speaker in this session is the Professor Rajendra Reddy. There is no need for introduction for Professor Reddy. All of you already know him. So please, Professor Reddy, it's your time is yours.
All right, thanks. Well, thanks very much for having me out here, and I'm delighted to represent ASSLD in this symposium along with Professor Kim, and I really want to thank the organizers for giving us this opportunity. So, Ray talked about the guidance document, and my task is to try and present real-life data relative to what the guidance document suggests that we use in patients with chronic hepatitis C. So again, to set the stage, I really want to go over the genotypes in that there is heterogeneity in the genotype prevalence in Southeast Asia, and it's different than the Western world in that you see relatively more genotype 3 and genotype 6 patients. I must say that you're not going to see any real-life experience from the U.S. With regard to genotype 6, but there is some data on genotype 3 that we could share with you. Most of it relates to genotype 1 patients in the U.S. So interferon traditionally had been the backbone of HCV therapy. We had used it for quite some time, but pretty much you can write an obituary, at least for genotype 1. There is a bit of use of interferon in genotype 3 patients, but largely interferon is a thing of the past if you do have access to all the oral agents. So there are multiple targets that you all recognize against which there are directly acting antivirals. You have the protease inhibitors, the NS5A inhibitors, and the NS5B nuke polymerase inhibitor, and the non-nucleoside polymerase inhibitors. Some of them are approved, some of them are investigational and hopefully will become approved soon. The ones in red are investigational, but hopefully will become available in 2016, such as velpatasvir as a pan-genotypic NS5A inhibitor, then of course the combination of grazoprevir and elbesvir. So you'll see these drugs come out, and then hopefully we'll be able to generate some real-life data. So again, the pill burden is variable. It could be as little as 1 to as high as 10 pills based on the regimen, but still it's a lot more palatable compared to the challenges we had with interferon and ribavirin. So in real life, it's very interesting. It's a rapidly evolving field in terms of drugs becoming available, and the platform has varied from region to region based on availability of drugs and also the development of drugs. So you could potentially see NS5B nucleotide polymerase inhibitor as a platform, and then you can combine it with an NS5A inhibitor, or it can be combined with a pan-genotypic protease inhibitor, and of course it could be in combination with interferon and ribavirin. Treatment durations have been looked at as little as 6 weeks to up to 24 weeks, and there's some differences between 1A and 1B. Cirrhosis dictates duration in some situations, and of course we've talked extensively about the cost being a factor. Or you can have an NS5 inhibitor as a platform, or you can have a protease inhibitor as a platform and combine it with other drugs. So in real life, the first wave of real-life data came about after approval of sofosbuvir in the US in December of 2013, and cimeprevir around November of 2013. And then this was used extensively in clinical practice in genotype 1 patients with or without ribavirin, and I'll share the data with you. So if you were to look at the ASSLD IDSA IAS guidance document, you'll find this is the more recently uploaded guidance document as of November 2015. There are 3 options here that are of sofosbuvir ledipasvir. Then you have the 3DA combination of ritonavir-boosted paritaprevir, umbritasvir, and dasabuvir, and then also had this option of sofosbuvir and cimeprevir. So ledipasvir, having trailed cimeprevir in its approval, at that time, we had sofosbuvir and cimeprevir available, and we used this quite a bit in genotype 1 patients, both in 1A and in 1B patients. We used this as a recommended therapy. So we collected data in the US through a consortium called HCV Target. There are at least 2 consortia that are operating in the US that collects real-life data. One is called HCV Target that my center is part of, and the other one is TRIO. And HCV Target collects data from academic centers as well as community centers, and you can see it's spread across the US, although there's a concentration of sites on the East Coast, and then you also have some European sites as well. So when we first looked at data after the availability of sofosbuvir and cimeprevir, we noticed that over half the patients were treated with sofosbuvir and cimeprevir, about 15% with sofosbuvir, cimeprevir, and ribavirin. And then there was some peg-ribavirin used along with sofosbuvir based on a study called Neutrino study. For genotype 2, it was primarily sofosbuvir and ribavirin. Over 99% had sofosbuvir and ribavirin. For genotype 3 as well, it was sofosbuvir and ribavirin. And if you were to look at response rates, recognizing in clinical trials there are very high response rates of around 90% or higher with sofosbuvir and cimeprevir, based on a study called COSMO study, looked at this in real life, and in real life there were quite good response rates, not about 90%, but close to 90%. If you were to look at overall response rates, the cirrhotics, non-cirrhotics, 1A, 1B, treatment naive, treatment experienced, with or without ribavirin, you'll see high response rates in real life, and there was no impact of ribavirin. So clinical trial data was close to being duplicated in real life with sofosbuvir and cimeprevir with or without ribavirin. And here you can see the comparisons in non-cirrhotics, F0, F3, F4, treatment naive, and then treatment experienced patients as well. You have a clinical trial data from Optimist 1 and 2 study, and HCV target data is alongside, and you'll see comparably good response rates in real life. So we've really been able to successfully treat patients in real life with this combination quite effectively. Now, I talked about this other consortium that also collects data from real life. It has academic and community centers. It's called HCV Trio, and there were 955 patients as part of this presentation, and they looked at per protocol analysis and looked at SVR in these patients. Out of 861, 762 had achieved SVR. And if you were to look at sofosbuvir, cimeprevir, with or without ribavirin, 1A and 1B, and look at overall genotype 1 patients, look at intent to treat, per protocol analysis, the brownish kind of bar representing oral regimen, whereas the light gray representing sofosbuvir, peg, and ribavirin. Intent to treat and per protocol analysis, you see high response rates out in the community with sofosbuvir and cimeprevir in genotype 1A and 1B patients. So again, in another database, it's performed as well in real life. And if you were to look at treatment discontinuation rates, low at about less than 5% with oral regimen, with interferon-based regimen, 12 weeks of sofosbuvir, peg, and ribavirin, a little higher at about 6%. So in the community as well, patients did quite well. Now then came along the second wave of sofosbuvir and ledapisphere, and the question is, how did it perform in real life in genotype 1 patients? So as you may know, this regimen is approved for 8 weeks in patients who are treatment naive, genotype 1, and are non-cirrhotic. So this analysis from HCV Trio looked at both 8 weeks and 12 weeks of sofosbuvir and ledapisphere in genotype 1, treatment naive, non-cirrhotic patients. And you can see high response rates of 95% or higher with either 8 weeks or 12 weeks. And if you were to look at response rates by fibrosis stage, there are good response rates. And if you were to look at response rates by baseline viral load, less than 6 million or greater than 6 million, the response rates were quite good. The 8-week regimen is recommended for treatment-naive genotype 1 patients who are non-cirrhotics. So it's interesting that there's, and then the viral load threshold is 6 million. So someone who had above 6 million, also some were treated with an 8-week regimen, although the number of patients was relatively small at 8 patients. So this tells you that in real life, the regimens, this regimen of sofosbuvir and lenacapavir of either 8 or 12 weeks performed quite well in genotype 1 patients. Now, what is very interesting is that the guidance document does not mention the 8-week regimen. It suggests that 12 weeks be used for all comers, although the label indicates that 8-week regimen can be used in genotype 1 non-cirrhotics or treatment naive. What is very interesting is that about 51% of patients with a viral load of less than 6 million, where 8-week regimen is adequate, were actually treated with 12-week regimen. So clearly, a 4-week additional treatment was used in half the patients, obviously driving the cost up. And then, as I pointed out, 8 weeks did as well as 12 weeks. So then there is another database, the HCV target database, that looked at real-life experience and had over 2,300 patients who were consented. At the time of the presentation at the last ASSLD meeting, the virologic outcomes in 1,000-odd patients were known. Most were treated with soft lenacapavir. Few were treated with soft lenacapavir and ribavirin. And you can see a breakdown by treatment duration, 8, 12, or 24 weeks. 24 weeks being for cirrhotics or treatment failures, particularly who've been exposed to a protease inhibitor. And here in real life, high response rates with 8, 12, and 24 weeks regimens and relapse rates under 10%. Here, there was, with soft lenacapavir and ribavirin, there was an 8% relapse rate, but the number of patients is relatively small to have any meaningful conclusion from that 8%. But overall, the message is that in real life, these patients with soft lenacapavir have done remarkably well in the background of genotype 1 infection. So what about genotype 3, which is obviously more relevant to this part of the world? And I want to preface my data presentation with a comment that decladisvir was only approved in the US in mid-2015, so there's really no reportable experience with decladisvir in genotype 3 patients in the US. Most of the data is on sofosbuvir and ribavirin or sofosbuvir PEG and ribavirin. Well, you all know that genotype 3 is a very interesting infection in that it has several unique features and is perhaps the last of the unmet needs. Historically, there have been lower sustained virologic response rates compared to other genotypes. There's an increased HCC incidence compared to genotypes other than 3. There's data to suggest that there's accelerated fibrosis progression compared to other genotypes. There is data on increased risk of mortality, and then there is, of course, increased incidence of steatosis in genotype 3. So genotype 3 is a unique genotype and presents several challenges. And if you were to look at the ASSLD, IDSA, and IAS guidance document, the recommended regimens are sofosbuvir and ribavirin for 24 weeks, Decladisvir and sofosbuvir for 12 weeks in those without cirrhosis, and without ribavirin for 24 weeks in those with cirrhosis. And then, sort of very interesting, the interferon ribavirin and sofosbuvir regimen has been placed as an alternative regimen, although if you were to look at data, that is quite an effective way of treating genotype 3 hepatitis C, as noted by the study called Boson study, where they looked at 16 weeks of sofosbuvir and ribavirin, 24 weeks of sofosbuvir ribavirin, or 12 weeks of sofosbuvir ribavirin and pegylated interferon. And you particularly pay attention to genotype 3, the best response numerically, although there are overlapping confidence intervals, was seen in patients who received sofosbuvir, pegylated interferon, and ribavirin for 12 weeks in the background of genotype 3. And if you were to look at a breakdown by whether they're treatment naive or treatment experienced, whether they had cirrhosis or no cirrhosis, you'll notice, at least numerically, sofosbuvir, pegylated interferon, ribavirin did the best. So this is perhaps one area where if you had only sofosbuvir available, you could use it in combination with interferon and ribavirin in genotype 3 patients. Now, what about real-life data with genotype 3? In the U.S., as I pointed out, decladisvir lagged behind other countries in terms of availability, such as Europe and well, primarily Europe, where it became available earlier than in the U.S. And so we only had regimens of sofosbuvir, ribavirin, or pegylated interferon, sofosbuvir, ribavirin. Relatively few were treated with pegylated interferon, sofosbuvir, and ribavirin, only about 20 patients, whereas about 168 had been treated with sofosbuvir and ribavirin, although, as I demonstrated, PEG, SOF, and ribavirin Boson study had a higher efficacy, but of course patients were enrolled here way before the Boson study data came out. And here it somewhat validates the Boson study data in that patients who received sofosbuvir, PEG, and ribavirin had higher response rates relative to just sofosbuvir and ribavirin. These are naive non-cirrhotics, experienced non-cirrhotics, naive cirrhotics, experienced cirrhotics. In any population you look at, particularly the treatment-experienced cirrhotics, you had higher response with sofosbuvir, pegylated interferon, and ribavirin, which still is the go-to treatment in genotype 3 patients if you did not have decladisvir available. Now, what about decladisvir plus sofosbuvir plus or minus ribavirin, genotype 3? This is real-life data from Germany and other European countries presented at ASSLD recently. 24 weeks of treatment is what is provided in genotype 3. And you can look at decladisvir and sofosbuvir, decladisvir, sofosbuvir, and ribavirin, all patients upwards of 85% sustained response. And it seemed like here at least ribavirin did not seem to make any difference. But again, I want to point out this is 24 weeks duration of therapy. And if we were to look at the French experience, compassionate use program of decladisvir and sofosbuvir with or without ribavirin, you'll see again high response rates, again not able to make any major difference or appreciate any major difference in 12 or 24 weeks, although I must say that the 12-week regimen had relatively fewer patients, particularly the ones who received DAX, sofosbuvir, and ribavirin. So as has been pointed out in the guidance document, 24 weeks of decladisvir, sofosbuvir for genotype 3 is the preferred regimen with or without the EASL guideline says use ribavirin, but the ASSLD guidance document does not emphasize that ribavirin is absolutely necessary. So, to summarize, effective therapies have become available for chronic HCV. Clinical practice has adapted well to the rapid changes in the availability of the various DAAs and used them effectively in the care of the patients. Real-life experiences have demonstrated SVR rates close to clinical trial data in genotype 1, but genotype 3, there is still, at least based on the data that we have thus far, there still has been a challenge in real life with regard to genotype 3. So with this, I'll end, and thanks very much for your attention.
Thank you for your excellent talk, Professor Reddy. So we will move to the last session for this topic, Asians' perspective. We learned from Professor Kim, who need to treat. As our guidance say, everyone has hepatitis C, need to treat. What about the Asian? And secondly, with what? It depends on the genotype, depend on the liver status, or naive or treatment experience. So this topic, Asian perspective, will be taught by Dr. Tila. It may be clinical impact for Asian and Thailand to treat the patient. So ladies and gentlemen, please join me to invite Professor Tila, please.
Thank you, Chair. I think we have seen a lot about the hepatitis C guideline, including ASLD guideline, EASL guideline, APASL guideline, and also Thailand guideline. So what I'm going to do now, I'm going to speak from the point of view of Asian perspective, because it might be some little bit different in management and clinical decision. Before we touching on the Asian perspective, I think we have to understand the specific feature that might something more common or more specific among Asia-Pacific region. Firstly, look at the prevalence of chronic hepatitis C. You can see that in our region, mostly the prevalence is be around 1 to 3%, except some countries had unusual higher prevalence, such as Pakistan and Mongolia can be over 10% prevalence. So put all together, we talk about hepatitis C should be the disease of veteran, but now you can see that among 170 million people chronically infected with hep C, approximately 90 million actually live in Southeast Asia. So we also the endemic area of hepatitis C, not only B. Secondly, look at the genotype. You can see that even some region, particularly in East Asia, genotype 1 is predominant genotype, but what different from the Caucasian? That's why we have different perspective. You can see that although the genotype common, but mainly is the genotype 1b. I will come back to touch on 1b. That's so East Asia, genotype 1b is predominant genotype. In South Asia, including India and Thailand, genotype 3 is a predominant genotype. And genotype 6 is a unique genotype that more common in Indochina. And back to before touching on interferon-based therapy, we have to come back to look at the host genome. It's an IL-20XB. As you see that among Asian patients, at least 80 to 90% have favorable IL-20XB-CC genotype. This is an interferon sensitive. That's why Asians do better respond than Caucasian with interferon-based therapy. So all this together is information that we have to set in our mind before coming to the guideline. So I think Professor Lei Kim touched on of this, so I don't need to explain more. But we know that all HCV infected patients with current really effective therapy, all of them should be treated unless they had limited life expectancy due to non-liver-related morbidity and cannot be treatable. So more critical than USA. We are in Asia Pacific region, not only human resource, the budget resource also really limited. So our area, I agree that prioritization is so critical and important. And this just give you some example, how can we prioritize who should be treated first. And you can see The upper box is those who should be prioritized to get treatment right now. That means those with advanced fibrosis cirrhosis, those with SAV-SBV co-infection, because disease progression is more common, it's faster than mono-infection. Patients who have indication for liver transplantation, patients have SCV recurrent after liver transplantation because this can reduce patient and graft survival. And also the patient who have suffered from extrahepatic disease such as mixed cholesterolemia, renal disease, sometimes it's more predominant than even liver disease, and those who have severe fatigue from extrahepatic manifestation. And for those, after those who really urgently require treatment, we come to those who justify treatment, those with significant fibrosis, defined as fibrosis at least F2, and those who have mild risk of transmission, because if we want to reduce this impact, we might to reduce the new case infection too, so that might justify to get treatment. And for those who still mild disease, no problem from extrahepatic manifestation and minimal fibrosis, they can wait. We don't see that they can't be treated, they can be treated, but after that we can fulfill the first group of the patients. And another issue that in Asia we still don't have all DAA agents. Mainly we have only PEG interferon 2A, 2B, and ribavirin in almost every country in Asia. But CPVS still remain in some country. Mainly most of the Asian countries had SORB and the Cartavir, and only I will say that less than 1/3 of the country in Asia that have these two agents. The other agent is approved in only the few countries in Asia and mainly in the East Asia. In Southeast Asia, only few countries that have another agent approved. So let's start from the Asian perspective. I think because some countries could not access and afford to the DAA therapy, PEG interferon ribavirin remain the treatment option for them. But at this the time of error, we should look at only easy to treat patients that remain achieving high SVR. For example, you look at the genotype 2, did from Taiwanese study. You see, if you had genotype 2 patient, this up to 150 patients treated with PEG interferon weekly plus ribavirin. And look at the week 4, you can see that genotype 2 with the PEG interferon ribavirin therapy, 87% achieve RVR. That means almost 90% of them achieve RVR. And those who achieve RVR, you can shorten treatment duration to 16 weeks. You can see SVR still 100%. Okay? And 100% SVR with PEG ribavirin genotype 2 achieve RVR. I will say that 16 weeks of PEG ribavirin may be the half price of PEG SORB ribavirin, or even 1/5 cost of the DA combination therapy, or even SORB ribavirin. The price still double the price of PEG ribavirin. So in this population, we might still consider. Even genotype 2 and 3 combined together, if they have the low baseline SCVNA below 400,000 IU per mil, achieving RVR, you can see that 16-week treatment duration with PEG ribavirin, 91% achieving SVR with almost same as the DAA. But the price, it might be less than a half of DAA combination therapy. Except in those who not eligible to PEG interferon, or those who in the country that they can reimburse interferon-free therapy. I think genotype 2, SORB ribavirin 12 weeks is also fantastic, give you a very high SVR from the study, 97%. And in those who not eligible to interferon, 93% SVR. But bear in mind that for genotype 2 and 3, even US recommend 12 weeks, as you say, that those with cirrhosis, treatment experience genotype 2, maybe 12 weeks is not adequate. We might extend to at least 16 weeks, or follow Valence study, it should be 24 weeks. That even increase the treatment cost up to 4 times higher than PEG ribavirin. So that's the first reason. And we come to another regimen from the Asian perspective. I think 12-week SORB PEG ribavirin is really one of the promising treatment options in Asia because it's effective pan-genotypic. It's effective with very high SVR above 90%, very well tolerated. Because of what? Look on our report many years ago. based on peglabovalin therapy for Hep C, treatment duration 24 to 48 weeks, you can see that about 84 to 90% of the patients still able to tolerate to treatment. That even longer, 24 weeks to 48 weeks. And look at who have to premature discontinue PEG. We found that 90% discontinue after 12 weeks. So when you come to 12 weeks, I will say that they can tolerate well, because 12 weeks, even before, they have problem and have to stop interferon. So put in this way, 12 week PEG sorblaborin, not only well tolerated because shortened duration, but more affordable in many countries in Asia, including Thailand. We're doing cost-effective analysis right now. We going to announce next year. Preliminarily, we found that PEG sorblaborin, the treatment cost is less than 50% of pardacastovir. You see? So this Asian perspective, if you treat this regimen, that means you can double the number of the patients who can be treated when compared with two DAA combination. So give you example of this PEG sorblaborin. You can see that it's really effective up to around 90%, even in cirrhotic patients. So that's why this, I think, from the point of Asian perspective, this remain one very promising, because 12 weeks for me, I think it's tolerable. I think you have the same experience. 12 week PEG in the front, your patient would be happy, and your prime minister would be even happier because they can save money. And population perspective will be happy because more of them allowed to be treated with the same budget of the years. And I'm not going to detail because you heard about interferon-free, ribavirin-free DAA therapy. Thailand guideline, ESO guideline, and everything really similar in both cirrhotic and non-cirrhotic. Just those without cirrhosis mainly can be treated for 12 weeks. On those with cirrhosis might require ribavirin for 12-week treatment duration and 24 weeks without ribavirin. But this expensive regimen. So come to the DAA. From the Asian perspective, we want to save the money and treat more patients. Luckily, that genotype 1B is a predominant genotype in East Asia, and even another country like Thailand, we are 30% genotype 1, but 75% of genotype 1 in Thai patients are 1B. And 1B, is the good news is it's more favorable to respond to some DAA combination regimen. I will show you the information. Let's start from the palitabivir, obitasvir, and desaprovir therapy. You can see this from PEARL 4 and PEARL 3 study in naive population. You look at this one first. For genotype 1A, you can see that without ribavirin, the SVR decline from 97% to 90%. But 1B, without ribavirin 12 weeks, you had SVR same as with ribavirin. So that's why the recommendation in treatment naive and even treatment failure for 1B population, even treatment failure from previous PEG ribavirin. You can see that 12-week treatment without ribavirin still achieve SVR up to 100%. Therefore, for genotype 1B in Asian, even treatment failure or treatment naive, it had no cirrhotic. We strongly recommend to treat this regimen without ribavirin. You can save the side effect and you can save the money. In the old day, we have free ribavirin if you use PEG. But now, once we stop using PEG, now they're selling you ribavirin. So in this way, you save the side effect and reduce the budget. And another issue is sorblaborin in genotype 1 compensated cirrhosis. You can see that if you give ribavirin 12-week treatment duration, it gives you a really high SVR. But if the patient cannot tolerate to ribavirin and require 24-week treatment, it also gives you really good. But bear in mind, even 12-week genotype 1 cirrhotic, if you give them only 12 weeks without ribavirin, you can see the price is, the SVR is almost same as 24 weeks. Now, in Asian perspective, you have to consider about cost effectiveness to increase another double price of treatment and to save just a little bit more patients. You might go to 12 weeks without ribavirin for compensated cirrhosis genotype 1 in Asia. Having said that, that means you can increase the number of the patients twice able to be treated when compared with 24-week treatment duration. Can we do that? We are genotype 1B predominant. We have to go back to some meta-analysis. This look at the soft ladies pathway with or without ribavirin in compensated cirrhosis. If you look at only genotype 1b, you can see that genotype 1b treatment duration 12 weeks and 24 weeks give you the similar SVR and really high up to 98 to 96%. And even without ribavirin, it also gives you really high SVR up to 96%. Put this all information together. If we consider carefully as we are people living in the economic constrained country, even cirrhotic, genotype 1, maybe we don't need to follow ASLD guideline or ESO guideline to give them ribavirin 12 weeks or without ribavirin for 24 weeks. If we just give soft ladies pathway only 12 weeks due to genotype 1b, you achieve the similar response. But doing this, you save another money to treat double number of the patient. That from Asian perspective, when we had to bear economic constraint in our mind all the time. And another issue is due to genotype 1b, the hallmark dual study is from BMS compound, is dacatazivir 60 mg daily in combination with isoniazid. This one never been improved in US and ESO because this not really good for 1A. And over there, they had more common genotype 1A. That one, this one only approved in Asia, now approved in Korea and Japan because it's cheaper and only dual therapy. And what the result? This result from hallmark study. You look at if the patient even treatment failure or treatment naive with this dual therapy, only dacatazivir and isoniazid, with the price is almost half of dacatazivir plus sofosbuvir. You can see that 90% SVR in treatment naive, over 80% in non-responder. Only one that you have to bear in mind. If the patient have advanced cirrhosis or have platelet count below 80,000, this regimen not good enough because SVR down to 23%. So we still able, in Thailand, we're going to approve this dual therapy in genotype 1b soon. And if they're not cirrhotic, if they have no thrombocytopenia, this one can even treat maybe 3 times more patients than soft plus dacatazivir. So this is another issue that why we had to consider carefully because we had unique specific feature. Genotype 6. During last symposium, we discussed about this. We still lack information. This only from electron study show 26. So I bear in mind that we don't know the DAA interferon-free exactly among genotypes, but it heard from many clinical trials that among Asian, you will see the result soon. We see more relapse. The SVR is not 80% like we expected. When they had large number, you will see the study reported soon from Vietnam in near future. So in this case, from Asian perspective, as we have more genotype 6, I still strongly recommend PEG, SORB, ribavirin is the best regimen for genotype 6, cheaper and more confirmed efficacy and more tolerable in Asia Pacific region. Genotype 3, you heard from Professor Reddy, is predominant genotype. It has some difficulty to treat, but if there are no cirrhosis, SORB, ribavirin for 24 weeks is good, and even the cirrhotic but compensated cirrhosis, no thrombocytopenia and treatment naive, this one also still provide you about 92% SVR. Only those with advanced cirrhosis or low platelet count, this may not good enough. So again, what shall we do for this cirrhosis? Even we have ALIGN 3 study, SORB, dacatazivir, you can see even treatment naive or treatment failure, they're good for non-cirrhotic, but cirrhotic, the SVR down to only 58 or 69%. So we go back to Boston study. Boston study is saying confirm that SORB, PEG, and ribavirin 12 weeks, the best efficacy SVR among genotype 3, even they cirrhotic or non-cirrhotic, treatment naive or treatment failure, particularly treatment failure genotype 3 cirrhotic, they give you the highest SVR. And back to the treatment cost again, it's half price of SORB, ribavirin. So again, come back to the beginning that I think SORB, PEG, ribavirin in Asian perspective is one of the promising treatment currently. ALIGN 3+ give you better efficacy, but you need to add ribavirin and might to extend duration to about 16 weeks. So that's why still about 89%, not as good as Boston study of PEG SORB ribavirin. So PEG SORB ribavirin is still good for all genotype, including genotype 6, cirrhosis or non-cirrhosis, naive or treatment failure. And we just heard today from Kasupia and Elbaswia that they can provide a 91% SVR in genotype 3 cirrhosis, but bear in mind, only 11 patients. We still need to keep an eye on this issue. Chairman, ladies and gentlemen, I would like to conclude from the Asian perspective in HCV treatment, which might quite different from European or American guideline. Prioritization of the patient for HCV treatment is essential in Asia where we have limitation. You can see that even though we know efficacy, due to living in Asia, sometimes we can't go to the base. We had to go to the second base to give more practicality to more patients. Therefore, PEG ribavirin remain a treatment option for easy to treat genotype, particularly genotype 2 in Asia. 12-week SORB ribavirin is very promising for genotype 2, particularly in those who are able to afford and not tolerable to interferon. SORB PEG ribavirin for 12 weeks, put all together, I do say that is one of the very promising treatment options for all genotypes in both naive and treatment experienced, and quite cost effective when you compare with interferon-free DAA therapy in our region. Genotype 1B non-cirrhotic can be treated with SORB ribavirin or DAA without ribavirin, and even cirrhotic 1B, if no low platelet count, 12-week SORB ribavirin still able to achieve SVR above 90% and save the money to treat more patients. SORB PEG ribavirin is a treatment option for genotype 3 cirrhotic. 16-week SORB PEG ribavirin is an option for free interferon therapy, but we had to keep an eye and look at the more number of the patient in the future study. And I thank you for your attention.
So if someone who have any question, please move to the nearest microphone.
Is there any questions from the audience? Maybe I want to ask first Professor Tira, is there any role of IL-28B test for patients in Asia, since you mentioned that PEG ribavirin is still options?
Yes, although I mentioned that PEG ribavirin still remain treatment option in Asia, particularly genotype 2, I would say that I don't recommend IL-28B CC-aline testing. The reason because we are over 80% or 90% CC-aline already. When you do this test, you spend more money to pick up about less than about 10% of the patient. Secondly, RVR is not different from IL-28B. If the patient achieve RVR, genotype 2, they over 90% SVR. So we can use RVR instead of mention this because it costs more money and it's not availability in many countries in Asia.
May I ask?
Yeah, Professor Win, please.
Although DAs are available, freely available in my country, sofosbuvir, Harvoni generic, and the declarative, those who are being treated is, I must say, less than 5% of the all chronic HCV carriers in the whole country. So when the Ministry of Health is developing a national hepatitis program, I proposed to the Ministry of Health that if you really want to have treatment outreach to the farmers, 80% of the people are living in the district rural villages where there is no electricity, where there is no central water supply. You really cannot be using the AASLD or APASL or EASL guidelines. It should be suitable for local people. So I propose that if you confirm that a person has chronic HCV infection, once that you don't go to viral load testing, because according to my previous experience, 90% of the and the ACV positive patients are, ACV RNA positive, and don't test for the genotype. You go straight with the sofosbuvir and ribavirin for 24 weeks. We are assisted by the Clinton Healthcare Initiative, CHI, and Duke University Department of Hepatology is also participating in a workshop. And I propose that as a form of treatment for the villages, because the drug is available, and we also have a factory that we can import the API and produce much cheaper than the Indian generics. And yet, the delivery of the healthcare to the villages will only be possible if you go without viral load testing or genotype testing. That's my proposal to the Ministry of Health. Could you please comment upon that?
That's a really good issue, but it had to be on basis of specific condition, like in Myanmar when you have generic sofosbuvir that's so really cheap, and that's why. And secondly, we did the study from last 3 years in Thai population. We found that actually the hepatitis C patient who able to access to the medical care is just about less than 10%. That means you deal with the tip of iceberg. Which I believe that in Myanmar as well, you deal with the tip of iceberg. So although you have really less expensive sofosbuvir generic, but if you try to expand 100%, it's practical and easy, don't need to do anything, but it might affordable. Because when you talk about, you used to treat Hep C about less than 10,000 patients per year, but when you want to expand to non-specialists, not do genotyping, just test HCV, then give in 2 drugs for 24 weeks. When you calculate together, although the cheap sofosbuvir, it will become really huge budget. And I don't believe that in Myanmar they will suffer only from Hep C. They still have a lot of disease that may be more critical than Hep C. So I answer you in the aspect of payer. I understand your aspect of the physician. You want to treat all. But at the government or payer perspective, sometimes they can't treat all. They might prioritize and continue treatment over time to cover more patients.
Okay, Professor Reddy, you may.
It's indeed a very interesting strategy that you're talking about, but I just had a question about ribavirin tolerability. You know, in the context of interferon and ribavirin, there was a certain tolerability issue, but now, even without interferon, ribavirin has an issue in terms of anemia. So, and help me here, you know, when I go to India and talk about ribavirin, they say most patients start with a baseline of about 10 grams, you know, hemoglobin, and they are chronically anemic. So what is it like in rural Myanmar as to what their hemoglobins are like and as to how well they tolerate ribavirin? And then, obviously, ribavirin has a teratogenicity issue, and you know, if in rural areas, obviously, you're treating young people. Is there a concern with ribavirin? So perhaps you can help me out answer those 2 questions.
As for this anemia, ribavirin-related anemia, according to my experience, Myanmar people are, I don't know, for some are very tough, and they can tolerate. Generally speaking, we have done with the United States Foundation for the rural patient anemia, hemoglobin is around 12, and they are very tough and can, my experience tells me that they can tolerate. So I propose that at least the blood parameters can be checked at the township hospitals. You just check the full blood counts every month. That should be enough. That I propose wildly in my wild suggestions, which government seems to accept.
Okay, yeah, yes, Professor Kim, please.
So a couple of thoughts. I don't know, I mean, the sofosbuvir if you have other agents than ribavirin and sofosbuvir combination, I think that may go better. We have a demonstration project at Stanford working with people in Rwanda in a rural community, and this is a randomized clinical trial where we randomize monitoring versus no monitoring, because viral load measurement is expensive, takes a long time there, and knowing what we know from our practice, that the viral load comes down quickly and there's no decision to be made, I think it will work, that patients will be successfully treated without careful monitoring of the course, with one caveat that viral load monitoring on treatment is helpful in making sure that the patient is taking the medication. So if your patients are not very well educated as to the risk of hepatitis, and they are just given a pill to take with no monitoring for a period of time, what the adherence may be and whether that may lead to problems down the road. As long as you stay away from NS5A agents, I think that will reduce the risk of further resistance in the future. But there are many different parts that will determine the success of a program like you're proposing. So I think monitoring is less of an issue, but taking a step back, and what are the treatment criteria if you have a really low cost drug? All of this prioritization discussion we're talking about, because it is so expensive. So it is, if it is cheap and it can be given to everyone with hepatitis C, then you won't be talking about this prioritization at all. So it's an issue that requires a little bit of a different thinking than what we're used to at this point.
I want to ask Professor Kim, if we have limitations in several countries in Asia. So if we have to propose just one combinations, what is the best combinations that it's suitable? I mean, in terms of the efficacy and also the no need for genotypic screening, etc. Whether it's sofosbuvir lenacapavir or sofosbuvir darolutamide or sofosbuvir simapravir, which one is that in your opinion?
That's a tough question. So if you have genotype 1, 3, and 6, the common denominator will be sofosbuvir and lenacapavir combination, because if you recall the slide that Tiara showed, that although lenacapavir-sofosbuvir combination is not being sought as an approved regimen, if you look at the limited experience using that combination, genotype 3 patients do fairly well. And the NS5A has in vitro activity against genotype 3 viruses as well. So for genotype 3 that works, genotype 6 the combination works, and obviously genotype 1 that combination works as well. So for the time being, I think that may be the combination, but as you know, there are more potent pan-genotypic medications that are coming out. So in the near future, we may not need to test the genotypes and give one drug to everyone. That will be, if you can make that cheaper as well, that will be the...
Thailand right now, we're going to update our essential drug list. So we got this question from the government to do cost-effective analysis on the principle of no genotyping. Because government believe that if we can skip genotyping, it can save a lot of money to treat more patients. So we got that question. So we're doing right now. Like Ray says, now we consider what regimen that we can be covered for all genotype in Thai patients. Bear in mind that we 50% genotype 3. So we pick up 3 regimens. The first one pick SORB ribavirin. The second one is SORB dacatavir. And we also put SORB lenacapavir. SORB will give us only one problem. We never see the full manuscript of genotype 3. It's only 2 studies from 8 gate. And that small number of patients that also have a good SVR for genotype 3 with SORB lenacapavir. However, even based on that, we put on this analysis. And because the price of in this analysis, we also ask pharma to negotiate the price. Even after finished negotiation, we still see that the treatment cost for solve PEG laboratory is still half than solve the criteria or solve the dyspareunia. But now we more negotiation, we might get a better price. They wait us to see the cost effectiveness first. Once they see now, they do the price.
One
Yeah.
more question. So, I mean, for genotype 1, that combination won't work, right? So that's the solve that won't work. That's the
Solve the dyspareunia genotype 1.
genotype 1B. Sorry, I'm geared to 1A patients in the US. Yes. So my question with regard to the very first you were asked about IL-28B genotyping is that as we are so cost conscious about hepatitis C treatment, and because Asian patients tend to respond well to interferon-based treatment, is it possible, has there been any data to try to utilize interferon in conjunction with some of the DAAs to shorten the duration than what is approved in the Western countries so that you can deliver treatment with a lower drug cost?
That's a very good question. But now, even solve PEG laboratory, we're thinking about we should do study comparing between 8 week and 12 week. That would be fantastic. Even we have another available. We should do, like you said, I think we might able to shorten to 8 week like a fantastic DA, but the interferon add another DA for 8 week.
Yeah, because of time constraint, we have to close these sessions. Very productive and very active sessions. And I want to thank all of this speaker for very informative lecture that they already gave us. Thank you very much for your attention. Thank you.